Hi. The place is shut down. It is in the middle of the pandemic. It's Monday, April the 20th of the year 2020. We are probably minimally 3 weeks away from being able to go back to some semblance of routine dental care. And this is a good time to talk about what it might look like or what it probably will look like and why. And I want to put your mind, if you're a patient, at ease over the concerns about what would be your risks of getting the coronavirus in a dental office. And I'll do that by simply explaining how it's going to happen here, what will be the routine normal for us now. To explain all of this, let me just kind of go back a little bit in history. Before 1980, essentially, we didn't have even the requirement of wearing gloves when treating patients with routine dental care. If the procedure wasn't going to produce bleeding, like the extraction of a tooth or some surgical procedure, the routine type of care dentists would provide at that time was what we all classically, affectionately called wet finger dentistry. At that point, the change became apparent when we had the AIDS epidemic. With the AIDS epidemic, also a virus, this one was transmitted through blood. That really changed the way dentistry from that point on would ever work again. And we had to adopt, happily, for our own protection and protection of others, a protocol that is now federally mandated, legally mandated, known as the blood-borne pathogen standard. All right, break it down. Blood-borne meaning the organisms that we were worried about would be transmitted through blood and saliva, through wet things, not aerosol, not air. Tuberculosis is spread by air, and that's why some patients with tuberculosis today are quarantined and are not in the general public if there are no ways to take care of their infection. Fortunately, tuberculosis is now a rare entity in that we were able to knock out the bacteria that caused tuberculosis to a great extent thanks to antibiotics. Antibiotics do not work with viruses. Viruses are much smaller and they're a different entity than bacteria. They replicate by entering cells, taking over the machinery, the factory of that cell, to produce more viruses that then break out and then spread. And each virus has different characteristics, and we're learning a lot about that in the general public now that we didn't know before as a general public. But the coronavirus is one of a number of viruses that are linked with flu and cold, and they are infectious. And the concern is that some strains are actually deadly. And we've had the SARS epidemic and we've had others. This coronavirus was worrisome from the beginning because of the fact that it was spread so easily. Fortunately, as the numbers are coming out now, it's not as high a risk to the general population as initially we worried about, but there was no data because it was a brand new virus. So this is historic in that this is the first time in history that the entire world is shut down to face and deal with a virus. And we know that that's important. We saw the ramifications of an unchecked virus back in 1917 and 18, which was called the Spanish flu and killed millions and millions of people. So no one wants to reproduce that. Secondly, our society is such that we want to protect our are weakest, who are most susceptible to death, terrible illness and death from this virus. That's the nature of the society in which we live, which I'm grateful for. But the other reason that we did what we did has to do with a lot broader concern, and that is our medical health care. If we are overwhelmed with this virus, or if we had become overwhelmed with this virus, then it would have essentially crippled us with regards to managing the health care of people who didn't have the coronavirus. And even now, we'll talk about the concerns of going to the ER and things, what we should and shouldn't do. And I will say that I am just in agreement that we have to have instructions and a point of control to where the information that's provided in this area is coming from a source that has authority, and I am not that source. So I, like you, believe that we need to listen to the experts, those who have the numbers, those who are looking at everything and can give us the best that they can with the information that they have at the moment, understanding that it's going to be in error, because that's the nature of the kind of mathematics and things that go on. We cannot predict with certainty everything about a virus going into the future. So all of its predictions, projections, and all of it will be wrong to some level. We don't know how much. But secondly, let's go back. We want to protect our healthcare system. We don't want it overrun. I do not believe that the objective is to stop the transmission of the virus, because I don't believe we can do that until we have a vaccine. So the spread of the virus will continue. Fortunately, it will not cause terrible illness, and maybe we're finding better methods of managing those who do get infected and get real sick. So there are medications and protocols, and even the plasma drawn from others who have the antibody can be life-saving options for people who really get sick with this virus that we didn't have a few weeks ago even. So all of that's very positive. So it is now time that we go back to work, but we have to do it in a way that is protective of not only patients, but the workers as well, including me. And that is simply to say that it wouldn't make any sense for any practitioner of any type to treat one patient, get sick and die. We need to be able to do this so that we are protected and our patients are protected. So it's a win-win for everybody that we do this correctly. So we have the bloodborne pathogen standard. I don't know what this new one will be called, but it will have something to do with aerosol protection standard, I believe. It will be the process of helping patients get the care they need while not transmitting that virus onto workers or the next patient. So in principle, it's the same as the bloodborne pathogen standard, except now we're dealing with aerosol. So here are what I can see as the changes, and there are probably things I will not think about, but things I have heard are, number one, I believe that we will be removing all of the magazines from a waiting room. I believe that we will not only be disinfecting the dental treatment rooms between patients, but we will probably be wiping off door handles and countertops or any place that a patient might touch, or us, on a routine basis, to break a transmission pattern. So that would be one. The protocols for disinfecting the operatory, the dental treatment room, following a patient will probably be dependent upon the procedure performed, with a simple question: was an aerosol produced or not? And if there's no way of knowing, it will be the worst case scenario that we assume aerosol was produced. In which case, countertops will be wiped off completely with antiviral kind of bactericidal things like we have even now. The kinds of chemicals that we use to disinfect do kill viruses. And we will be washing our hands a great deal before and after all procedures as before. But we will also be gowning protective gear. And one of the interesting things that will probably occur is we will all be using what's called the N95 mask, and we've been hearing about this in the news for months, for weeks, I mean. The N95 mask has been around, and it is simply a mask that has the ability to protect against virus going through the mask because its pore size is much smaller. It's also used commercially with people who use paints and other things to protect them from aspirating chemicals. So the N95 masks, there are some other masks that have the same level of protection that have different names or numbers. Essentially, those are the same mask, only made either in Europe or in China. And under our emergency protocols, we can use those sorts of things, but I think that most of us are going to want to use those made in America, if at all possible. And we'll see. We'll see how that works. Right now, if we were to open up dental care, we would be at a shortage for these kind of masks. And so this kind of equipment will have to be available for us before we can open the doors. In order for it to become available to us, it has to be established that there's an adequate supply of these masks and other personal protective equipment materials in the medical setting. We can't rob the medical setting to take away these kinds of things to put them into the dental office. Consequently, dentistry is on a little bit of a hold right now. Now, what about emergencies? If you have a dental emergency right now and you're in pain, you need to contact a dentist, contact me, any other dentist, and you need care, and you need it now. And the reason for that is we do not want you going to the emergency room. We don't want the load on the emergency room, but we also think that you would be more at risk going into the emergency room with a toothache for getting the coronavirus. So why take that risk? Okay, so if we can separate out the dental needs of emergency care and do them in dental offices, even now, that's what we need to be doing. We can do things that will slow down or stop. We can certainly stop pain and put people on antibiotics. And we can do some limited procedures that would not create as much aerosol. For example, in my particular area, being periodontics, if I have something I have to treat, I can use a hand instrument and treat it with a hand instrument and not use an ultrasonic tip that basically vibrates at 1,000 beats per second, and that aerosolizes everything. So we need to be able to manage that now. And again, I'm talking about not having the N95 mask and trying to get somebody out of discomfort. We can do something. We will manage it. Once we have the N95 mask and we'll have face shields and other things, then we're going to go back to using dental handpieces and ultrasonics and all the rest as before, but it's going to slow us down as in terms of the exchange of patients from one to the next. And there won't be a lot of congregating of patients in waiting rooms. So right now, a lot of people are having patients wait in their cars. When they come up, they'll call saying, I'm here, I'm in my car. We call them in when we're ready, or we'll come out and get you, and we'll escort you in and past the waiting area into the operatory and then back out again. This is going to last probably for a number of years, but not forever. And the reason it won't last forever is because we will ultimately have immunity as a population for this coronavirus. It will not be something that we have to worry about forever. Secondly, I do believe we're going to get a vaccine. Once the vaccine is available, then a lot of this will go away in terms of the distancing issues that we have in general. This protective distancing is the necessity of what we're dealing with. But I don't think we're going to go back to what it was before completely, because I think we're going to note that maybe the flu and colds will be dramatically reduced in the population from now on, simply because we've learned some things that have helped us not get these kinds of viruses. For one thing, we probably will not be doing a lot of handshaking in the future. I don't know that that is a necessary thing in order to be cordial and greet people. So we're going to learn other ways to do this, and we're just going to have to smile at each other a lot more and have verbal greetings and rely less on a firm handshake and sincerity of a handshake, which I think a lot of people have felt has been probably one of the biggest spreaders for viruses that we've had. So washing hands a lot will be continuing. Hopefully we will pick up some good habits from all of that. I think I will. But dentistry has been at the forefront of that sort of behavior, I want to tell you, simply because of the work we do. So I don't know that it's going to be that much different for me as it once was in terms of understanding the importance of hand washing. But in the general population, I think it's going to pick up. We're going to, as a population, really appreciate how hand washing does affect our level of health. And then there are many, many other things I can't think of right now that I know that will be taking place and changing the way we operate from now on. So that's all I have for now. I hope you're staying safe, healthy, well. If you're bored and you want to listen to my book on the joy of flossing, which isn't just about flossing, by the way. It is now audio. You can listen to it from my website. There's a link to that on my website, to the audio version of the Joy of Flossing. It runs at about 55 minutes. If you want to download it as a podcast, it is on a podcast, but the podcast I do primarily for dental hygienists and dentists, having to do with supportive care, periodontal care in their offices, and how we do this back and forth. I think that would pretty quickly become a boring thing for you to listen to. But if you go on to that podcast, you can find the Joy of Flossing as a download, and you can do it that way. So if you need to talk with me, please call my number. It's on my phone, or I'm not sure if it's on the website. I don't think I would do that. But you can get a hold of me. You can send me a message or whatever, and we can set up a telemedicine meeting, meaning I will talk to you by phone, and we will figure out what your concerns are. This also may be something in the future which we're going to do a lot more of. We may be doing a lot of the intake, the histories, and what your concerns are, and do that by telemedicine. And that will also reduce transmission, because talking like I'm doing now is spreading virus. And again, I think we shouldn't get overly weirded out over this. We've been dealing with viruses our entire lives, and we'll continue to deal with viruses the rest of our lives. It's a matter of management and controlling and seeing how healthy we can be as we go forward. So I wish you the best.